So I want to welcome everyone to Family Medicine Grand Rounds. My name is Dr. Inez Cruz, and I am the Director for Professional Development. Nicole Rubio, who is also on the line, is the Coordinator for Professional Development and Grand Rounds. So any questions that you have can also be directed to Nicole. Today's event, of course, number is 197047, and today is July 15th. We've provided a couple of directions at the bottom of the slide on how you can register for this event via cell phone, smartphone, or computer. Of course, thank you for putting your microphone on mute. This makes presentation easier. Of course, attending to the presenters is always another, and being engaged in the session. Dr. Katerndahl has requested that any questions you have, please hold them till the end, and then he will answer questions once he is done. And then, of course, please submit an evaluation at the end of the presentation. Evaluation is extremely important, not only for Grand Rounds, but especially for the presenters. So today is South Texas Regional Family Medicine Grand Rounds. We are also providing this in conjunction with our educational partner, South Central AHEC. We've already talked about CME transcript. This is how you can get in contact with CME if you have any specific questions. They're really quick to respond, so please feel free to reach out to them. The next slide talks about AAFP. If you're an AAFP member, they also respond very quickly, so we have provided you with their phone number as well as their email. So Dr. Katerndahl will be presenting Trauma-Driven Life today. I will go ahead and give the floor over to Dr. K. Thank you.
Thank you, Inez. Thank you for having me today. So I want to talk about the effects of trauma that we experience. I have no conflict of interest, which Inez didn't tell everybody about, but is really important. So let's get started. So the objectives are to be able to recognize and diagnose trauma-related disorders. We'll talk about treatment of these disorders using both pharmacologic and non-pharmacologic approaches, and talk about monitoring response and complication risk. So unfortunately, exposure to trauma is fairly common in American society. So the pie chart talks about how many children are exposed to major trauma in their lives. And as you see, only 35% of children are not exposed to any source of major trauma, and many are exposed to more than one source. Adulthood trauma is even more common. So 90% of adults will be exposed to at least one lifetime major trauma in their lives. 50% of adults experience assault, violent death of a friend or family member, a natural disaster or accident or fire. And multiple exposures are actually very common. So in people who have had at least one exposure, the mode, which is the most common response of how many exposures, is 3. So it's actually, we can view this as kind of an evolutionary process. So studies have suggested that 60% of males and 50% of females will have some lifetime exposure to trauma. Of those, up to 33% will then go on to develop acute stress disorder, and 8% of males and 20% of females who are exposed will actually go on to meet criteria for PTSD. So let's talk first about screening for trauma. Do we need to screen everybody, or who should we be asking about trauma? So one set of recommendations are that you screen for trauma in patients who have a history of inappropriate anger, they have repeated non-specific complaints that your workups are failing to find anything. Another time you may want to screen for trauma is those people who have insomnia with frequent awakenings, especially if it sounds like these might be nightmares waking them up. Here's some suggested interview approaches. So you might ask people, have you ever experienced or witnessed a serious injury or assault? Have any family members or friends ever experienced serious violence? Occupational exposure. Have you ever worked in a job that exposed you to serious trauma? And finally, for childhood exposures, you might want to start by asking if they remember everything in their life as a child, or have they lost memories? Because dissociation is fairly common in childhood trauma. Or ask them, do you feel that you may have been abused as a child, even if you don't actually remember it? These are questions I frequently use. Symptoms after exposure to trauma are actually super common, and they can be almost anything from physical, emotional, cognitive, behavioral symptoms. These are all very common after being exposed to trauma. So what do you want to do if you're aware that somebody has been exposed to trauma? One is you want to let them know that those symptoms are very common, so that they shouldn't be unduly alarmed if they start experiencing some of these. There's a technique called psychological first aid. So what that involves is maintaining frequent contact and engagement with the patient, gathering information like what their current needs are, what their current concerns are, addressing safety and comfort in their lives, making sure they're in a stable environment. Practical assistance. Do they need help with finding support? Do they need help with transportation or access to services? Connection with social support. We're going to see social support here is very important in trauma exposure. Information about coping, because poor coping can actually make things worse than better. Connection with collaborative services. And you want the person to feel that they have hope in their lives, that they can do this. So you want to focus on coping and self-efficacy. There are certain self-help behaviors that you could emphasize. So exercise is felt to be valuable. Self-regulation through things like mindful breathing techniques, monitoring their sensory input so that they don't get overly stressed from a sensory standpoint. Healthy lifestyle, so adequate sleep, relaxation, a positive diet, certainly avoidance of alcohol and drugs. That can only make the situation worse. How about technical management here? So talking about the trauma is ultimately good, but you don't want to force it. So only if the patient wants to talk about the trauma should you do that. You want to avoid re-traumatizing the individual. So if you force them to talk about a very stressful trauma, that may actually make things worse. There's techniques called psychological debriefing, critical incident stress therapies. These are actually not recommended anymore because they all had the potential to re-traumatize the individual. You do want to monitor them frequently for warning signs, things like insomnia, nightmares, paranoia, anger outbursts, withdrawal and isolation, or outright psychiatric symptoms like anxiety, depression, and substance abuse. These are all warning signs that mean we need to do something. And you want to avoid benzos. Studies have actually suggested that those who experience major trauma and resort to benzo therapy may actually increase the risk of developing PTSD. What about acute stress disorder? So that's the next step up, right? So who of those who are exposed to major stress will go on to develop ASD? So those who have lost a loved one from the trauma, who experience depression after the trauma, loss of home or community, extended danger exposure. So if it's not just a single exposure, but an ongoing exposure, if they've had prior mental illness or have low self-esteem or sense of self-efficacy, those who cope through avoidant therapy, or those who have had prior trauma exposure or don't have access to adequate social support. Those are all settings that make acute stress disorder more likely. How about the prevalence? Oops. That's not what I wanted to do. I am screwing up here. All right. So generally the prevalence is higher in those situations where interpersonal assault has been the source of trauma. After MVA, the incidence can be as high as 21%. After assault, as high as 19%. And also you want to be aware of associated symptoms that patients may not readily contribute, but are very important. Things like catastrophic interpretations. So they are exposed to trauma, but they assign some new catastrophic interpretation to it. Those who become very impulsive or experience panic attacks, these are also warning signs. Here's the DSM-5 criteria. So, and as you'll notice, many of these criteria overlap heavily with PTSD. So you can think of acute stress disorder almost as early, less severe PTSD. So you have the intrusive symptoms, the negative moods, the dissociative symptoms, the avoidance, and the arousal symptoms that are also common in PTSD. The duration, though, is so ASD will begin anywhere from 3 to 30 days after the trauma. So it's something that comes on almost immediately. And they experience significant distress or impairment. So what's the treatment? How should we be managing if these patients, we diagnose them with ASD? So the only real proven treatment is brief psychotherapy to prevent the development of full-blown PTSD. And CBT seems to be the most effective intervention at this point. Medications, so do not routinely use psychotropics as the consensus. There's no great evidence that any of these do anything in ASD. And there's very good consensus that you want to avoid benzos. Monitor them. So again, frequent visits are important. There's a scale that I've included at the end of the PowerPoints called the ASD scale, and it seems to be very good at predicting who with ASD will go on to develop full-blown PTSD. So it has excellent likelihood ratios, and if you use a cutoff of greater than 56 on the scale, those people are at high risk for developing PTSD. And certainly if ASD is not resolving, those people need to be referred. So who needs to be screened for PTSD after trauma exposure? So some people would advocate that you want to do periodic screenings with a validated instrument in everybody who gets exposed to trauma. Certainly in people with ASD who the ASD is not resolving, those who develop warning signs or have dissociative episodes, those are people who really should be screened for PTSD. The PTSD screening. So 50% of people with ASD will go on to develop PTSD, all right? Symptoms usually begin within 3 months of the trauma. So who develops the full-blown disorder? What's the time frame? So 25 to 30% of PTSD develops within 6 months of the traumatic event. An additional 30 to 36% develop within 12 months of onset. And there's a condition called delayed expression of PTSD, which could develop long after the trauma. The problem is when you go back on these people that have this label of delayed expression, most of these people have had some symptoms almost immediately after the trauma. Yes, they may have not met full-blown criteria, but they had some symptoms early on. So the screening tools that I would recommend are either the SPAN or the PC-PTSD. These instruments are both included at the end of the PowerPoints. So these generally have moderately good positive and likelihood ratios. What are risk factors? So who is at higher risk for developing PTSD after trauma? So there's certain personality features that make you at high risk. So those that have had prior trauma as a child, those that have pre-existing mental disorders, those that have things like borderline or dependent personalities and have low self-esteem. Those are people who are going to be at higher risk for going on to PTSD. Their environment, so those that have a family history of anxiety disorders, those that have lower socioeconomic status are also at higher risk. And then the stressor itself is important. So was it a life-threatening trauma or physical trauma? We've recently become aware that obstetrical trauma is also a high risk for going on for PTSD. So things like preeclampsia, miscarriage, intrauterine death are high-risk situations. If the person experiences a sense of horror or helplessness during the trauma, that also is high risk. And if they dissociate during the trauma, they black out basically. In terms of military experience, those who suffered a penetrating injury or were involved in killing other people are also at higher risk for going on for PTSD. And then post-trauma, again, no social support, poor coping. Those people who've had other losses or life events around the trauma. People who had ASD already are more likely to go on to PTSD. And then certain triggers can bring on PTSD-related symptoms. So external triggers can be almost anything, any sensory input. So sights, smells, sounds, people, places, things, dates, nature, news coverage, confining situations, relationships that are stressful, arguments, hospital exposures, funerals, all of these things have the potential of serving as external triggers to PTSD symptoms. But even internal triggers, so sensations, senses of discomfort, emotions, feeling about others, these can also trigger PTSD symptoms. So this summarizes DSM criteria. So again, there's a lot of overlap with ASD. Let's talk about what changes there were from DSM-5, from DSM-4, because PTSD was one of the disorders that had significant changes from DSM-4. So number one, the traumatic event. So they added recurrent occupational exposure as a potential traumatic event. So first responders, people who work in emergency departments. But they dropped the necessity of having an emotional response to the trauma. The re-experiencing criterion was rewritten. For children, they added a developmentally appropriate criterion. Avoidance criterion actually got split, so into two different aspects. So the avoidance behaviors and negative cognitions are now separate in DSM-5. Arousal criterion got revised and material was added to it. And I'll point out that there are people advocating to change the name of post-traumatic stress disorder to post-traumatic stress injury as a way of minimizing the barrier to some people that are feeling stigmatized by having it as a disorder. So in DSM-5, the actual or threatened death, serious injury or violence, you have to have at least one of these following. So a direct exposure, witnessing somebody else experiencing it, learning of a traumatic event of a close family or friend, and then the experiencing repeated or extreme occupational exposure. You have to have at least one intrusive symptom. So that can be memories, dreams, nightmares, flashbacks, experiencing symptoms based on exposure to a cue of some sort of trigger. At least one associative avoidance of stimuli associated with the trauma. So things like avoidance of distressing memories, avoidance of external reminders of the trauma, at least 2 negative cognitions with it. And I'll point out that one of them is negative beliefs or expectations about others. And so we see people who become paranoid after the trauma, distorted cognitions about the causes, the consequences, blaming themselves or others, sense of detachment or estrangement, at least 2 alterations of arousal. So this can experience things like anger outbursts. They're common. Hypervigilance. So it's not uncommon for patients to tell us that they start seeing shadows out of the periphery of their vision. This is probably a manifestation of hypervigilance. Startle responses, sleep disturbances, problems concentrating, and then duration. So the disorder has to go on for more than a month, but won't begin until a month after the exposure to the trauma. Remember, if it starts within a month, then we're probably talking about ASD here. Significant distress and dissociative symptoms, be aware, these are very common. So one manifestation is pseudo-hallucination. So hallucinations, true hallucinations, differ from pseudo-hallucinations in that if you hear voices as a pseudo-hallucination, usually you can identify that the voice is within your head. It's not external to you. A true hallucination, you feel like the voice is external to you. What they found is dissociation. Dissociations are actually have more impact than psychotic features in PTSD. Dissociations can often lead to negative cognitions. And there is a risk for auditory hallucination. So a victim of trauma may hear the voice of the perpetrator of that trauma in their head saying negative things to them over and over again. PTSD is associated with conversion disorder and blindness. There's a condition called sensory defensiveness, which 80% of people with PTSD may experience. So that these individuals may misinterpret sensory events, withdrawal socially, develop unusual eating habits. The symptoms may wax and wane with stress in the environment, and it can impact their self-esteem, their safety, and their sexual relationships. They may actually develop what's called anosognosia, which is denial or unawareness of neurologic deficits. So they may deny neurologic symptoms that they're experiencing. So prevalence of symptoms very high in studies of people with PTSD. 91% of people will have intrusive thoughts or sensations. 90 or 83% will have avoidance of stimuli. Things like decreased loss of interest in things, 85%. Poor concentration, 90% of people. So all these symptoms are very common in PTSD. Comorbidities are also extremely common, and men and women usually have similar symptoms, with the exception of alcohol abuse is much more common among men than women. And up to 85% of people will actually have more than one comorbid mental disorder with their PTSD. And attempted suicide is also super common. 20% of people will attempt suicide. PTSD can affect relationships. So it affects couples in that they develop poor adjustment to the disorder. It affects your parenting abilities. So people with PTSD have perceived parenting as more of a challenge. Their parenting behaviors are generally poorer than those without PTSD. They may perceive childhood anxiety and physical abuse are actually increased. They may numb out or avoid parenting because they get less parenting satisfaction, and there may be increased parent-child aggression in these relationships. What about PTSD therapy? Well, the literature, basically, there's too much evidence. So once 9/11 and the Afghan and Iraq wars developed, research exploded in PTSD. And so we actually have a problem of having too much evidence, in a sense. You have to figure out how to sort through that. So let's focus first on systematic reviews, and we'll look first at pharmacotherapy reviews. Medication effects seem to be helpful in these reviews at decreasing symptomatology, depression, and disability. 60% of people respond to medication, although full remission is not very common. There are only 2 FDA-approved medications, paroxetine and sertraline, for PTSD. There are some medication comparisons. So in one comparison, paroxetine seemed to be better than fluoxetine and sertraline. In another comparison, sertraline, venlafaxine, and nifazodone, which we don't use anymore because of the risk of liver damage, seem to be better than other medications. Augmentation drugs, so risperidone has been found to be useful as an augmentation drug in one systematic review. And in people who respond to antidepressants, those who stop the antidepressant had a 3-fold risk of relapse within 1 year. What about psychotherapy? So again, systematic reviews abound here. And what we found is that trauma-focused CBT, stress management, and EMDR, which is eye movement desensitization and reprocessing, all have been found to be effective in systematic reviews. There are some novel approaches that systematic reviews suggest might be helpful. So mantra therapy in one review seemed to be more effective than stress management and problem solving. And a technique called written exposure seemed to be equally effective to more formalized cognitive processing therapy. An advantage to this is that the written exposure therapy required fewer sessions. How about comparisons? So trauma-focused CBT and stress management seem to be more effective to other techniques in one systematic review. And another one suggested that EMDR was more effective than trauma-focused CBT. So group CBT seems to be more appropriate as an adjunct rather than a primary therapy. But again, there's almost too much therapy here. So a few systematic reviews have focused on combining pharmacologic and non-pharmacologic therapy. And in one of those, there did not seem to be any difference from monotherapy here. In another one, psychotherapy seemed to be equally effective to combined therapy, and both of those seem to be superior to pharmacotherapy alone. So the American Family Physician has had a couple of articles since 2013 on the management of PTSD. So in the most recent one, if we look at compare level A evidence, so the most recent one said only CBT had level A evidence, whereas the older one said that trauma-focused CBT, SSRIs, and NSRIs all were first-line therapies. In terms of level B therapies, there's a wealth of level B empathy therapies in the most recent one, whereas the older one only mentioned prazosin as an adjunctive therapy, and again emphasized avoiding benzos here. And level C therapies pretty much were involved in a variety of therapies. And the older one said to recommended optimizing monotherapy first, before combining therapies and recommending avoiding antipsychotics as monotherapy. Now, the reason benzos are really not recommended here is, number one, remember, people with PTSD are at increased risk for substance abuse, but also there's some evidence that those receiving psychotherapy respond less well to the psychotherapy if they're taking a concurrent benzo. It seems to mute their response. What about clinical guidelines? So again, we have too many guidelines. So since 2004, there's been 10 different guidelines on the management of PTSD. So let's look at some of the consensus among these guidelines. So generally they agree that in people exposed to trauma, do not engage in psychological debriefing because of the risk of re-traumatization. They agree in terms of ASD, the approach is trauma-focused therapy, and I put at the bottom of the slide what they consider trauma-focused therapies here. And again, there's no recommended pharmacotherapies for either trauma exposure or ASD. In terms of PTSD, so the trauma-focused therapies and EMDR seem to be first line. The guidelines don't consistently recommend what's second line here. They do agree, generally the guidelines recommend on SSRIs as first line, but they disagree on what's the second line therapy. So one approach was to compare these guidelines in terms of we know individual therapies and how people respond. So we can compare guidelines. So those guidelines that advocate trauma-focused therapies over medications seem to outperform, okay? The guidelines that say medications are just as good. And in terms of second line, there again is no consensus, no consistent performance in what's a second line therapy, all right? So I think we can all agree that trauma-focused therapy is our first line approach. And that's pretty consistent across systematic review and across guidelines. So what about patient preference? What about the patient who comes in and says, can I just take a pill? So your response is, well, Taylor Swift says, Band-Aids don't fix bullet holes, right? So medication alone is not really going to heal you, all right? So what about, so we know we can start with an SSRI, but that's not going to heal you, all right? How about symptom-specific treatments? Well, there are some treatments for specific symptoms. So aggression, anger outbursts may respond to mood stabilizers or to antipsychotics. Flashbacks may respond to carbamazepine. SSRIs may be beneficial also in flashbacks. How about re-exposure distress? So going into situations which may trigger symptoms, propranolol may actually be beneficial. And I want to specifically mention this here. So there's actually a study that shows that for people who are engaging in trauma-focused therapies, who have a lot of distress when they go through the therapies, having them take propranolol 30 minutes before their therapeutic session has actually been shown to be beneficial to them. So that's something you can give them to take prior to psychotherapy. Psychotic symptoms can respond to antipsychotics. In suicidality, because the risk of suicide is higher, those people who are having a lot of suicidal thoughts, you may want to consider mood stabilizers. And the one that's been shown to be effective here is lithium. And there is a little bit of evidence that omega-3 fatty acids may reduce suicidal thoughts. And I want to specifically focus on nightmares. So a lot of the guidelines really don't focus a lot on nightmares. And there's a lot of ambivalence in the guidelines of whether you treat nightmares in any specific way or not. I recommend focusing on the nightmares and treating nightmares because those PTSD people who have nightmares seem to have increased symptomatology from it, related to it. They are at an increased risk of suicide, and the nightmares may persist long after other symptoms of PTSD abate. And so the number one, the most agreed medication or the best studied medication is prazosin. And the minimally effective dose seems to be 3 milligrams, but we usually titrate up to that. So 1 milligram for 3 nights, then 2 for 3 nights, and then up to 3. The maximum I've seen used is up to 20 milligrams, and this study actually advocated you could add an additional 5 milligrams in the morning, but that doesn't make a lot of sense if you're treating nightmares, from my perspective. In somebody who can't take prazosin or they fail to respond, a second-line agent is terazosin, but because of its long half-life, if you're starting terazosin, you want to start very low and increase it slowly. So I usually won't start more than 1 or 2 milligrams because of the risk of hypotension. But you can go as high as 20 milligrams. In those who don't respond to non-selective alpha blockers, my third-line agent is cyproheptadine, but it definitely is a third-line agent. I don't think the evidence there is very strong. If you want to go to psychotherapy, I think the best evidence is for a technique called imagery rehearsing therapy. Now, there are some other potential therapies, but they have just not been well studied yet that we can advocate. All right, what's the course? What's the prognosis in PTSD? So the prognosis is definitely affected by the proximity to the event, the traumatic event, how long you've experienced the PTSD, and how intense it is. Generally, as the patient ages, the arousal, the avoidance, the negative symptoms tend to gradually improve over time, but their health perceptions may gradually worsen over time if it's not addressed. Spontaneous resolution of symptoms is possible. So 50% of people experiencing PTSD will recover on their own within 3 months of onset of the PTSD. The mean duration is 36 months after among those receiving treatment, okay? So once you start treatment, the person should not expect that within a couple of months they're going to be symptom-free. It's going to be a longer process. Predictors of a good response to therapy is early onset, early and ongoing support rather, rapid onset of treatment. So those people who get into therapy sooner after the trauma have a better prognosis. Avoidance of re-traumatization. So that's why you don't want to push people to discuss their trauma too early if they're not ready for it. Absent of comorbid mental disorders or substance abuse, and how they handle anger seems to be important. Those people who repress their anger, who don't give in to anger outbursts, seem to have lower mortality rates, lower symptomatology, and less disability from their disorder. So what's our role as primary care physicians? So it's across the board. So we're responsible for screening, for making the diagnosis, for educating the patient for what they should expect after experiencing trauma, for monitoring symptoms, because again, monitoring is extremely important here in terms of how the response to the trauma develops. We want to monitor for comorbidity. One instrument you can use is called the PTSD checklist of DSM-5 or the PCL-5. And again, I've included it at the end of the PowerPoints. So in people who cross a threshold, those who score higher than 33 seem to be at high risk for going on to develop PTSD or worsening PTSD. And the value to the PCL5 is monitoring people once they've been diagnosed with PTSD. So a change, an increase or decrease of 10 points on the PCL5 is a good marker of whether people are getting better or worse. So primary care physicians can engage in treatment and certainly referral, but we're also the team leader. So frequently those with PTSD need to have a team of people helping them, and we're the team leaders. So my recommendations, here's my bottom line recommendation. So I recommend you have a low threshold for screening, both for trauma and for PTSD itself. Avoid benzos. So benzos really don't have a role in either response to major trauma or in PTSD itself. So after acute trauma, I recommend psychological first aid. So all those things we talked about, being supportive, giving them a sense of hope, but also monitoring for warning signs and referring early when those signs seem to be developing. In acute stress disorder, the only proven treatment really is brief psychotherapy. So they need to be seeing somebody who knows how to handle this. And again, you want to monitor for warning signs and refer. In those with PTSD, I think all patients are going to need trauma-focused therapy, right? And that needs to be an ongoing message with your patients. Yes, you don't force them to go against their will, but they need to understand to fully recover, a pill is not going to do that. They are going to need to get into psychotherapy, all right? Assess and treat nightmares, and I recommend prazosin as your first treatment for that. You want to assess and treat anger, because anger can be very devastating for people, all right? So either antipsychotics or mood stabilizers can be effective treatments for anger control. You want to assess and treat psychotic features, especially paranoia or disabling hallucination. So somebody who says, I see shadows out of the corner of my eye, I don't worry about putting those people on antipsychotics. People who hear voices telling them to hurt themselves or other people who are extremely paranoid, those people may get into trouble because of their psychosis. And I think antipsychotics are valuable there. And you want to monitor them in an ongoing way for both substance use and for suicidal thoughts. What are the indications for referral to psychiatry? So number one, if the patient asks for it, I don't fight them. I just send them to psychiatry. If they cannot access trauma-focused psychotherapy any other way, then a psychiatrist is certainly appropriate. Concerning symptoms, so people who have ongoing suicidal thoughts or who have made suicidal attempts, either currently or in the past, those who are homicidal, those that have significant dissociation, because remember, dissociative identity disorder is also a possible product of trauma exposure. I think those are people who are better handled by psychiatry. Those who are actively abusing substances, I don't think we're going to do well with those people. I think they need to see a psychiatrist. And if you feel unsafe, if the person is so paranoid or having so much difficulty that they can't control their anger and you feel unsafe, I think those people need to be referred on. So here are the summaries of my main points. So in terms of trauma, exposure to trauma is very common in our society, both for children and adults. Psychological first aid and monitoring of warning symptoms is important, and if those are present, they need psychotherapy. Avoid benzos after trauma exposure. How about those who develop ASD? So onset is usually within the first month after the trauma. So this is something that comes on soon after exposure to the trauma. Brief psychotherapy can help prevent the development of PTSD in these people. Again, avoid benzos in ASD. For those who have full-blown PTSD, so this can begin months after exposure to the trauma. It doesn't have to come on very quickly. All patients eventually need trauma-focused therapy. SSRIs, NSRIs can help, especially in people who are very resistant to getting psychotherapy. This is a temporary measure, but you're only delaying it. I recommend treating specific symptoms as needed, and again, avoid benzos. Hopefully that's a consistent message out of this talk. All right, so we are going to be sending the PowerPoints around, so you will have access to them. So what questions do people have at this point? I'm not hearing anybody, so we need to unmute people. Nicole, is there a way we can unmute everybody?
Give me 1 second. Okay, I've got everybody unmuted here.
All right, who's got questions? Maybe I put everybody to sleep.
I liked your presentation, Dr. K. Something you were talking about that I thought was interesting was I was listening to this podcast on psychology and stuff, and they were talking about debriefing therapy and various types of therapy for PTSD. And the main factor in whether therapy was helpful was basically consent. Like when you're forcing people to debrief when they may not be ready to, you're re-traumatizing them. And I think that goes into like safe exams as well. How we deal with like sexual assault trauma and things like that. So I thought that was interesting to hear about that. And also you bring up an interesting point that I wonder about. So like, I've never seen anyone do this, but I could see when I was thinking about it, I was thinking like, who would give benzos? People don't give benzos to anybody anymore, really. But then I was trying to imagine, not really. And I was trying to give myself a situation in which I do that. And if someone was coming to me like hysterical after a trauma or whatever, you know, like, or in the ED when they're like acutely agitated and stuff, they may give them benzos, but like, so could you give them like anything if they're super agitated? Would you give them hydroxyzine or something? Like we do that in the hospital a lot when people are like,
I think hydroxyzine's fine. I think you're right. I think in that circumstance, if they're extremely agitated, you could rationalize giving them a benzo, but you need to make sure they understand this is a short term. You're getting this for 1 week, 2 weeks. That's it. I'm not refilling this, okay? So, because understand, it can make the situation worse, not better.
Yeah, I guess you'd have to assess like the risk of substance use. This is echoing to me.
Other questions? So Nicole, are you going to email the PowerPoints around to everybody or what?
Yes, I'm going to send it to the listserv along with the evaluation link for today's session. So I'll send that here in just a moment to everybody.
So in other words, they can't access the PowerPoints without filling out the evaluation. Is that it?
Well,
That's a
We
great
would
idea.
like to do that, but we'll be nice. I'll send it out.
Maybe we can withhold their paycheck if they don't do the evaluation.
I haven't tried it, but no, but if there's anybody also that is on here that is not on the listserv for some reason, you can contact me at rubio.n@utesca.edu if you would need those PowerPoint slides as well.
Maybe we could load the PowerPoints into Epic. Then nobody will have access to them.
You would crash the system, Doctor.
Great. Well, if there are no other questions, I'd like to thank Dr. K again for taking the time to present today.
Thank you, guys.
Thanks, Dave.
Thank you.
Thank you.
Thanks, Dr. K.
David.